In part two of this three-part series on the most important things RCPs must know about mechanical ventilation, we will be discussing guidelines for ventilator discontinuation. My name is Bill Miller, and I have no conflicts of interest to disclose with regard to the subject matter of this presentation. After graduating from the respiratory therapy program at Butte College in Northern California, I moved to Sacramento and began working at the University of California at Davis Medical Center. And I worked there for 30 years and retired. While I was working there, I was also working at a Kaiser hospital. I worked there for 7 years. And about 25 years ago, I started teaching mechanical ventilation at Napa Valley College in Napa, California. I also teach at American River College mechanical ventilation in Sacramento. The ventilator discontinuation issues in this discussion include determining the readiness for a spontaneous breathing trial, performing a spontaneous breathing trial, and what to do when patients fail their spontaneous breathing trials. After reviewing several thousand articles in the world literature involving ventilator discontinuation, a task force facilitated by the American College of Chest Physicians, the American Association for Respiratory Care, and the American College of Critical Care Medicine produced evidence-based clinical practice guidelines for managing the process of ventilator discontinuation, or liberation from mechanical ventilation. The task force published 12 recommendations based on the highest level of available evidence, reported as Grade A, Grade B, or Grade C evidence. GRADE is an acronym for Grading of Recommendations, Assessment, Development, and Evaluation. Grade A is scientific evidence provided by well-designed, well-conducted controlled trials, randomized and non-randomized, with statistically significant results that consistently support the guideline recommendation. Grade B is scientific evidence provided by observational studies or by controlled trials with less consistent results to support the guideline recommendation. Grade C is expert opinion supported by the guideline recommendation, but scientific evidence either provided inconsistent results or was lacking. These evidence-based guidelines were first published back in 2001 in the journal Chest. In 2002, it was published in the Respiratory Care Journal. Currently, these guidelines are the AARC Clinical Practice Guidelines for Ventilator Discontinuation. They remain relevant today. Recommendation number 1. In patients requiring mechanical ventilation for greater than 24 hours, a search for all the causes that may be contributing to ventilator dependence should be undertaken. This is particularly true in the patient who has failed attempts at withdrawing the mechanical ventilator. Reversing all possible ventilatory and non-ventilatory issues should be an integral part of the ventilator discontinuation process. This recommendation was based on Grade B evidence. There are a number of reasons why a patient may be ventilator dependent. Brainstem strokes, central apnea, and narcotic medications are conditions that affect the respiratory center. The patient may be ventilator dependent because of an imbalance between the ability of the respiratory muscles and the workload imposed on those muscles. The respiratory muscles may be weak because of respiratory muscle atrophy from disuse or myopathy associated with critical illness, neuromuscular blocking agents, or corticosteroids. An increased workload imposed on the respiratory muscles could be from increased airway resistance or low lung compliance, or a need for a large minute ventilation. And dynamic hyperinflation also causes increased work of breathing. And nutrition, electrolytes, hormones, and oxygen transport are all metabolic factors that can affect ventilatory muscle function. In patients who require a high level of PEEP and or FiO2 or are hemodynamically unstable should have those issues addressed before withdrawing ventilatory support. And psychological factors may be among the most important non-respiratory factors leading to ventilator dependence, and they can be some of the most difficult to manage. So you're the night shift respiratory therapist, and you're just finishing your shift, and the day shift's about to come on, and it's policy in the ICU where you're working for you to screen all of the patients to determine which ones should have a spontaneous breathing trial at the beginning of the day shift and which ones should not. In bed 3, you have this patient, Cody Doe, and he's been on the ventilator for about 2 days, and he's post-cardiac arrest. He's awake and alert, and he's breathing spontaneously with pressure support of 8 and a PEEP of 5. He's got a FiO2 of 35%. He has a normal blood gas. His heart rate is 88. His blood pressure is 108/70. He's receiving dopamine 20 micrograms per kilogram per minute. So, what would you recommend? Spontaneous breathing trial or not have a spontaneous breathing trial? We'll find out in recommendation number 2. Recommendation number 2. Patients receiving mechanical ventilation for respiratory failure should undergo a formal assessment of discontinuation potential if the following criteria are satisfied. 1. Evidence for some reversal of the underlying cause for respiratory failure. Number 2, adequate oxygenation, PO2 FiO2 ratio 150/200, requiring a positive end expiratory pressure 5 to 8, FiO2 0.4 to 0.5, and pH greater than 725. Number 3, hemodynamic stability, as defined by the absence of active myocardial ischemia and the absence of clinically significant hypotension, a condition requiring no vasopressor therapy or therapy with only low-dose vasopressors such as dopamine or dobutamine, less than 5 micrograms per kilogram per minute. Number 4, the capability to initiate an inspiratory effort. The evidence for this recommendation is grade B. These 4 criteria in recommendation number 2 are not to determine if the patient is ready for extubation, is to determine if he's ready to do a spontaneous breathing trial. So let's see if our patient, Mr. Cody Doe, meets these criteria. Number 1, evidence for some reversal of the underlying cause. Well, he was intubated for cardiac arrest, and now he has a heart rate of 88, so there is at least some reversal of his underlying cause. Adequate oxygenation, he's on 35%, and his PEEP is 5, so he has a normal blood gas, so apparently he's oxygenating fine. That isn't a problem. Let's skip down here to number 4, the capability to initiate an inspiratory effort. Well, he obviously is not on any neuromuscular blocking agents or comatose and apneic because he's on pressure support and breathing spontaneously. So he meets that one. Number 3, hemodynamic stability. Well, we don't know if he has myocardial ischemia because that wasn't in the information that we had there. So we might want to, check that out. But where the problem is he is on dopamine at 20 micrograms per kilogram per minute, and that is high dose vasopressor. So he would not meet the criteria based on that one. They need to get him down to where he only requires less than 5. It should be noted that some patients with chronic hypoxemia may be ready for ventilator discontinuation, even though they don't meet all of the criteria in recommendation number 2. So now you're the day shift respiratory therapist, and during rounds, you report to the physician that Cody Doe has passed screening for a spontaneous breathing trial. So the resident says he wants a 30-minute spontaneous breathing trial with 5 of CPAP. But the pulmonary fellow tells the resident that the SBT should be for 30 minutes and with a low level of pressure support. The attending physician says he believes that the patient should be disconnected from the ventilator and placed on a T-piece for the SBT. But he says the decision should be made after consulting with the respiratory therapist. And that's you. So what do you recommend? the CPAP spontaneous trial with 5 CPAP, the low level of pressure support spontaneous breathing trial, or take the patient off the ventilator and do the spontaneous breathing trial with a T-piece. And for how long would you recommend? Recommendation 3. Formal discontinuation assessments for patients receiving mechanical ventilation for respiratory failure should be performed during spontaneous breathing rather than while the patient is still receiving substantial ventilatory support. An initial brief period of spontaneous breathing can be used to assess the capability of continuing on to a formal SBT. The criteria for which to assess patient tolerance during SBTs are the respiratory pattern, the adequacy of gas exchange, hemodynamic stability, and subjective comfort. The tolerance of SBTs lasting 30 to 120 minutes should prompt consideration for permanent ventilator discontinuation. The evidence for recommendation 3 is grade A evidence. Patients who fail a spontaneous breathing trial usually do so right away, shortly after the trial is started. And the respiratory therapist should stay with the patient for about the first 5 minutes. And at the first sign of intolerance, the patient should be placed back on the ventilator and given a comfortable level of ventilatory support. There's no evidence showing that 30-minute or 120-minute spontaneous breathing trials are any different in outcomes. And so I would recommend the 30 minutes rather than the 120 because the patient gets off the ventilator faster. When you're doing a breathing trial with a low level of pressure support, the patient is getting some help. So some physicians like to have their patients off the ventilator and prove that they can breathe spontaneously without any ventilatory support. And the task force recommends that a CPAP trial or a T-piece trial or a low level of pressure support all give the same results. However, there is more recent studies been done that show that the patient with some pressure support during their spontaneous breathing trial produced a higher rate of extubation success and was associated with a trend towards lower ICU mortality. Your patient, Cody Doe, has passed his 30-minute spontaneous breathing trial with a pressure support of 5, and he does really well, looks good, no rapid shallow breathing, no respiratory distress, his blood gas is good, and when you suction him, he coughs forcefully and he has very small amount of sputum. So you report this to the resident physician, and the resident is kind of concerned about the patient's airway. He tells you that Cody Doe was a very difficult intubation, and the emergency department physician had to try several times before he could get the endotracheal tube in, and that he could possibly have an airway issue resulting in an unsuccessful extubation. So what do you recommend? Recommendation 4. The removal of the artificial airway from a patient who has successfully been discontinued from ventilatory support should be based on assessments of airway patency and the ability of the patient to protect the airway. The evidence for recommendation 4 is grade C evidence. Your patient, Mr. Cody Doe, is not comatose and he doesn't have a brain injury, so there's no reason to believe that he wouldn't be able to protect his airway. And you suctioned him and he had a strong cough, so he will have the ability to clear secretions. The problem is the traumatic intubation, which could result in an upper airway obstruction, and so you recommend a cuff leak test. So the doctor agrees, and you go to the patient's ventilator and put it in assist control, either pressure control or volume control. He's probably not going to have much of a leak with that 10 of pressure support and breathing spontaneously. So you listen with your stethoscope and let the cuff down, and you hear a leak, but doesn't sound like much of a leak. And you look at your ventilator and you see that the difference between the inspired and expired tidal volumes is only 30 cc's, and that's not really very much of a leak. So you report this to the physician, and he says he's going to give the patient some systemic steroids, and we'll wait about 4 hours before extubation. So after lunch, you come back to the ICU and check the EMR, and you see that the doctor wrote an order to extubate Mr. Doe. He also ordered for an intubation tray and a tracheostomy equipment to be at the bedside, and that's probably a good idea, don't you think? When you enter Mr. Doe's room, you notice his heart rate is, his respiratory rate is up a little bit, and he appears to be anxious. And the nurse says that Mr. Doe is anxious, and he's anxious about getting extubated, and that she's given him some more sedation. So you extubate Mr. Doe, and there's no stridor, and you listen to his lungs, and the lungs are clear. You have him cough, he coughs pretty good, and you stay there for about 5 minutes, and everything looks good. He's breathing very comfortably, and so you leave the room to go do your afternoon rounds. But about 15 minutes go by, and you hear code blue bed 3. So you rush down to bed 3, and as you enter the room with about 50 other people, and the nurse is bagging the patient, and you take the bag and mask ventilate the patient, and look up at the monitor, and you see sinus bradycardia, and the nurse says that he became apneic and bradycardic, and so she called the code for this respiratory arrest. And the doctors come rushing in the room and intubate Cody Doe. Recommendation 5. Patients receiving mechanical ventilation for respiratory failure who fail an SBT should have the cause for the failed SBT determined. Once reversible causes for failure are corrected, and if the patient still meets the criteria listed in recommendation number 2, subsequent SBT should be performed every 24 hours. This recommendation is based on grade A evidence. There is always a physiologic reason why a patient would fail a spontaneous breathing trial, and it's important to try to determine what that reason is before doing more spontaneous breathing trials, because he'll just fail again if you don't fix the problem that caused him to fail. You want to look at his pain control and sedation. Is he fluid overloaded? Does he need bronchodilators? Has he got cardiac issues that need to be addressed? About a half hour after Mr. Doe has been re-intubated, he's awake, and of course you've adjusted the ventilator, have him in assist control while he wasn't breathing, and you got the respiratory rate set for 14 breaths per minute, but he seems anxious, and he's triggering the ventilator for about 24 breaths per minute. So the resident tells you to change the vent settings to where they were before he was extubated, pressure support of 10, and he wants to try another spontaneous breathing trial tomorrow. So tomorrow morning, do a SBT and hopefully extubate. The attending physician is in the room, and he asks your opinion as to why the patient failed extubation. You explained to the physicians that Mr. Doe passed his spontaneous breathing trial, and he had, after he was extubated, he had no stridor, and his lung sounds were clear. He looked good to go, and that you think that he got reintubated because of the drugs that the nurse gave him and caused him to become apneic. And the pulmonary fellow says if the drugs are the reason, we shouldn't wait till tomorrow, just wait for the drugs to wear off and extubate later today. The attending physician thinks that's reasonable. It recommends consultation with the respiratory therapist. So what is your recommendation? When a patient fails extubation and is re-intubated, it is recommended to wait 24 hours before attempting another spontaneous breathing trial. One reason for that is that whatever caused the patient to fail probably isn't going to get fixed in a very short amount of time. And another reason is that he may have developed some respiratory muscle fatigue when he failed. So, the respiratory muscle is a very thin muscle and it fatigues very easily. And a fatigued muscle is a weak muscle, and the remedy is to wait 24 hours at least. So now our patient, Mr. Cody Doe, is recovering from sedatives because we determined that the reason why he failed was because he became apneic because of drugs. And so what do you recommend? It is dangerous to leave a patient intubated who no longer needs ventilatory support. Failure to recognize readiness for extubation will result in longer stay, higher cost, excessive sedation, longer exposure to potentially toxic airway pressures and volumes, and increased risk of infection. On the other hand, premature ventilator withdrawal can lead to airway loss, compromised gas exchange, aspiration, inspiratory muscle fatigue. A failed extubation is associated with an 8-fold higher odds ratio for nosocomial pneumonia and a 6 to 12-fold increased mortality risk. The challenge then is to balance aggressiveness with safety. So you changed Mr. Doe's ventilator settings back to the pressure support of 10 that he was on before. But you look at him and he doesn't look like he's breathing very comfortably. And so you recommend to the resident that you think we should turn up his pressure support to make him a little more comfortable. And the resident doesn't agree with that. He says that we would have to wean him back down before we could do a spontaneous breathing trial. Well, the pulmonary fellow agrees with you and says we should increase the pressure support to whatever level makes him comfortable. The attending physician says that the important thing is to make the patient comfortable, even if that requires going back to assist control. He turns to you and says, "Isn't that right?" What do you say? Recommendation 6. Patients receiving mechanical ventilation for respiratory failure who fail an SBT should receive a stable, non-fatiguing, comfortable form of ventilatory support. The evidence for this is grade B. So you explained to the 3 physicians that Mr. Doe needs more ventilatory support. He's uncomfortable, and the attending physician is correct. The important thing is to make this patient comfortable. Whether it's increasing his pressure support or putting him in a different mode, a SIMB or a volume control, pressure control, whatever makes the patient comfortable is the right mode. There's no best mode and there's no weaning mode. And you say that if we try too hard to wean down his pressure support to some minimal level before doing a spontaneous breathing trial, we run the risk of causing respiratory muscle fatigue, and then he will fail his spontaneous breathing trial. Then you say, it is very possible that this patient is not going to be comfortable no matter what mode you put him in. This patient is suffering from anxiety, and he needs some sedation, in my opinion. And he should receive some kind of sedation that is not a respiratory depressant so that he will pass his spontaneous breathing trial and will successfully extubate. Recommendation 7. Anesthesia, sedation strategies, and ventilator management aimed at early extubation should be used in post-surgical patients. This recommendation is based on grade A evidence. Post-op patients may fail a spontaneous breathing trial if they're in a lot of pain, especially after upper abdominal and thoracic surgery. It's painful to take a normal-sized breath. Also, if the patient is getting too much pain medication, it may depress his respiratory drive and fail his spontaneous breathing trial. So optimal sedation management and pain and also ventilator strategies may shorten the duration of mechanical ventilation for those patients. In Egan's fourth edition back in the 1970s, Egan recommended that post-op patients should not be extubated for 24 hours after their surgery. Today we know that isn't true. We know that the patients have way better outcomes if we get them off the ventilator as soon as possible, in just a couple of hours. And today, though, we have modes like MMP and ASV, and using those modes has been shown to lead to earlier discontinuation of mechanical ventilation. Recommendation 8. Weaning discontinuation protocols that are designed for non-physician healthcare professionals should be developed and implemented by ICUs. Protocols aimed at optimizing sedation also should be developed and implemented. This recommendation is based on grade A evidence. Scientific evidence provided by well-designed, well-conducted controlled trials with statistically significant results consistently support the Recommendation 8 guideline. These clinical trials, using evidence-based protocols, showed significant reduction in the mean duration of mechanical ventilation and cost of care. The duration of mechanical ventilation and the cost of care can be reduced even more with a nurse-implemented sedation protocol. Both the respiratory therapist ventilator management protocol and the nurse-implemented sedation protocol should be coordinated, and the protocols should be evidence-based. Recommendation 9. Tracheostomy tubes should be considered after initial period of stabilization on the ventilator, when it becomes apparent that the patient will require prolonged ventilator assistance. Tracheostomy then should be performed when the patient appears likely to gain one or more of the benefits ascribed to the procedure. The evidence for recommendation number 9 is grade B. When breathing through a tracheostomy tube, the airway resistance is much lower, and so the patient won't have to work so hard to breathe. Also, especially in COPD patients or any patient who has a lot of dead space ventilation, when you are breathing through a tracheostomy tube, your anatomical airway dead space is reduced significantly. About 1/3 of that dead space is in that upper airway. And the patient will be much more comfortable with that endotracheal tube out. And he will be able to eat and communicate much better, and he will have a lot more mobility, which, you know, the physical therapist can work with them more if they're able to move around more. You're working at a hospital in Northern California. It's a medium-sized hospital. It's a trauma center for the region. And you're rounding with the trauma surgeons one morning, and as you go into bed 6, you have a patient named Billy Joe Ray Bob Doe. His friends all call him Bubba. And Bubba is 67 years old. He was in a motor vehicle crash and had a lot of broken bones and had a lot of surgeries. And on day 4 in the ICU, he developed pneumonia. And the next day, he was in ARDS, and he required high PEEP and high FiO2. And that lasted about a little over 2 weeks, and he started to improve. So they did a spontaneous breathing trial, and he failed, and so they trached him. And now he's been having daily spontaneous breathing trials. 8 consecutive days he's failed his spontaneous breathing trial, and his stay in the ICU has already been for 1 month now. The surgeons are discussing a plan as to what to do with Bubba. He is ventilator dependent, they believe, and don't think he'll ever get off the ventilator. They call him failure to wean. And so they decided that they should send him to this care facility across town where they accept ventilator dependent patients. Now, you know that this place across town is not a really good place. They're not going to try to wean him off the ventilator or do much of anything except just care for him there. And other patients you've seen go there are there about 3 or 4 weeks, and then they come back with pneumonia. And so you have some suggestions. And so what do you suggest? Recommendation 10. Unless there is evidence for clearly irreversible disease, spinal cord injury, or advanced ALS, a patient requiring prolonged mechanical ventilatory support for respiratory failure should not be considered permanently ventilator dependent until 3 months of weaning attempts have failed. So you explain to the surgeons that this patient has only been in the hospital on the ventilator for 1 month, and we should wait for 3 months before making the determination that Bubba is permanently ventilator dependent. And you'll go on to explain that you understand that they need to get him out of the ICU there. They need to free up that bed, and that he will have to go somewhere else. But you don't think it's a good idea for him to go to that hospital across town. So the chief trauma surgeon says, well, if we don't send him to that place across town, where are we going to send him? And aren't all those places the same? And so you say, no, they're not all the same, and I will get back to you. Recommendation 11. Critical care practitioners should familiarize themselves with facilities in their communities or units in hospitals they staff that specialize in managing patients who require prolonged dependence on mechanical ventilation. Such familiarization should include reviewing published peer-reviewed data from those units, if available. When medically stable for transfer, patients who have failed ventilator discontinuation attempts in the ICU should be transferred to those facilities that have demonstrated success and safety in accomplishing ventilator discontinuation. In a meta-analysis of over 30 studies on post-ICU weaning from prolonged mechanical ventilation, half of those patients were able to successfully be discontinued from mechanical ventilation when they are transferred to units dedicated to that activity. You log on to one of the computers at the nursing station and do a little bit of searching, and you find what looks like to be an ideal place to send Bubba. It's a place where they take ventilator patients that are dependent and they wean them off of the ventilator. So you print up the information and you take it to the trauma team and hand the paper to the chief trauma surgeon. The chief trauma surgeon reads the information sheet that you gave him to the rest of the trauma team. Santa Clara Valley Medical Center Ventilator Dependent Program, a note to physicians. The Respiratory Rehabilitation Unit provides around-the-clock respiratory management for ventilator-dependent patients. Our specialization in invasive and non-invasive respiratory technology has resulted in an outstanding record of successful vent weaning and home discharge. The Trauma Center is also equipped with a helipad and accepts patients from across Silicon Valley. Having the highest level of emergency response on the same campus as the Rehabilitation Center means that patients don't have to be transferred to other facilities if the need for a higher level of care arises. And the trauma surgeon says, well, this does sound ideal, and he thanks you for your assistance and says he's going to give Santa Clara Valley Medical Center a call. Recommendation 12. Weaning strategies in the prolonged mechanical ventilation patient should be slow-paced and should include gradually lengthening self-breathing trials. Recommendation 12 is based on grade C evidence. So now you're working at a rehabilitation facility, and you're the lead therapist in the respiratory rehab unit, and you get called to come see this new patient that just came in. His name is Billy Joe Ray Bob Doe, also known as Bubba. And when you look at Bubba's chart, you're really happy to see that the respiratory therapist at the previous hospital did a really good job of documenting Bubba's care. So you review the documentation in Bubba's chart, trying to determine why he is ventilator dependent. You need to know why he's ventilator dependent to put together a plan to get him off the ventilator. So you see that his airway resistance and his compliance are normal, so there's not an imposed workload on his respiratory muscles. You look at the waveforms on his ventilator and they all look normal. You don't see any dyssynchrony or any issues, no high pressures. And you look at his blood gases and they all are pretty normal. He's not got a oxygenation problem. His CO2 and pH is normal with a normal minute ventilation. There's no documentation of any problem with cardiac issues or any kind of hemodynamics. And his chest x-ray and CT scan all are clear. And so you measure his negative inspiratory force and his maximal expiratory pressure and his vital capacity, and you see that those are all low. His spontaneous tidal volume is low when you take him off the ventilator, and see his breathing pattern is rapid and shallow. And as soon as you disconnect him from the ventilator just for a minute to see how he breathes, he appears very anxious. So given all this information, can you tell why Bubba might be ventilator dependent? So you call the pulmonary physician who's going to be caring for Bubba and report to him your assessment and your recommendations. And you believe that he is ventilator dependent because of respiratory muscle deconditioning. And so you recommend a slow weaning process where we take him off the ventilator for short periods of time and gradually lengthening those breathing trials. And that also he seems to be anxious, probably from 8 failed spontaneous breathing trials in the past, and he's going to need somebody to sit with him while he does these breathing trials. And it might even be beneficial to call in a psychological consult for Bubba. In 2016, the American College of Chest Physicians and the American Thoracic Society published new guidelines for discontinuing mechanical ventilation in critically ill adults. These latest guideline recommendations are based on many studies published in the last 10 to 15 years. Conducting a spontaneous breathing trial with pressure support of 5 to 8 was more likely successful, produced a higher rate of extubation success, and was associated with a trend toward lower ICU mortality than spontaneous breathing trials using T-piece or CPAP. Evidence showed a trend toward a shorter duration of mechanical ventilation and a shorter ICU length of stay, and a trend toward lower short-term mortality in patients who are managed with sedation minimization protocols. Patients at high risk for failure of extubation may include patients with hypercapnia, COPD, CHF, or other serious comorbidities. And the non-invasive ventilation should be used immediately after extubation to realize the outcome benefits. Evidence for recommendation 4 demonstrated that patients who received early mobilization had shorter duration of mechanical ventilation and were more likely to be able to walk at hospital discharge. Low rates of serious adverse events, including arrhythmias, have been reported. The evidence supporting recommendation number 5 demonstrated that patients managed with a ventilator liberation protocol spent fewer hours on mechanical ventilation than did patients without a protocol. In addition, management with a ventilator liberation protocol led to being discharged from the ICU earlier than management without a protocol. The evidence suggests that patients with an absent or insufficient cuff leak are at increased risk of post-extubation stridor and unsuccessful extubation. Risk factors for post-extubation stridor include traumatic intubation, intubation longer than 6 days, large endotracheal tube, female sex, and reintubation after an unplanned extubation. For adults who have failed the cuff leak test but are otherwise ready for extubation, the expert panel suggests administering systemic steroids at least 4 hours before extubation, and that a repeat cuff leak test is not required. The recommendations in these guidelines are the result of expert panel interpretation of the existing evidence and how it may be applied in clinical practice. Only one recommendation, extubation to preventative non-invasive mechanical ventilation in high-risk patients, is strongly suggested. All others are considered conditional recommendations. Way back in 1994, Esteban did a study looking at the best way to get people off the ventilator, the fastest way to get people off the ventilator. Should we use pressure support ventilation and wean that down until they are on a very small amount of pressure support, or using SIMV and wean down the respiratory rate? Or don't wean, just leave the patient in assist control and do a once daily spontaneous breathing trial. And this is the group of patients that got off the ventilator faster. Pressure support weaning versus SIMV weaning versus not weaning. Just check the patient every day to see if he can breathe on his own. There has been this belief that if a patient is in assist control, his respiratory muscles are going to get weak because the ventilator is doing all the breathing. And that turns out not to be true at all. If the patient is triggering his ventilator and the respiratory rate on the ventilator is not so high that he doesn't need to breathe, then the respiratory muscle is going to get all the exercise it needs. When the respiratory center fires, the muscle contracts. Also, it's important to understand that the purpose for the daily spontaneous breathing trials is not exercise. It's a test, simply a test to determine readiness for extubation. A rapid shallow breathing index greater than 105 has been shown to predict failure. It's a pretty strong predictor of failure. But a rapid shallow breathing index less than 105 does not necessarily mean the patient is ready to extubate. It's not a good predictor of successful extubation, just a good predictor of failure. Consider this, a patient is breathing 36 breaths per minute and his tidal volume is 390. The 390 might be a normal tidal volume for this patient. You calculate the rapid shallow breathing index and it's 92. So you call the doctor and the doctor says, well, what's his rapid shallow breathing index? And you say, well, it's 92. He says, good, let's extubate him. Well, wait just a minute. We got to look at some other things here. 36 breaths per minute, this patient is tachypnic. And if you calculate his minute ventilation, he's breathing 14 liters per minute. And you probably wouldn't be wise to extubate a patient who has that high of a ventilatory demand. You would want to try to find out why he's breathing 14 liters per minute. Does he have a metabolic acidosis? Does he have a lot of dead space ventilation? Look at all of the things that might be causing a patient to need such a big minute ventilation. Also, with pressure support ventilation, there's more dysynchrony than you might think. If you start watching for dysynchrony with pressure support, especially higher levels of pressure support, you'll see a lot of these patients have missed triggers. So to tell if they have having missed triggers, you put your hand on the patient's abdomen or over his diaphragm, and you watch the waveforms on your ventilator. And when you can feel the patient making every inspiratory effort, and when you feel the patient making an inspiratory effort, but you don't see a breath for that effort, that's a missed trigger. And you could have a patient who is breathing 40 times a minute, but only triggering every other effort. And so the ventilator will report to you 20 breaths per minute when he's actually breathing 40. And it will miscalculate the rapid shallow breathing index. And also some use the NIF as a predictor for readiness for extubation. And it turns out that's not a very good predictor. Studies show that the NIF predicts readiness for extubation correctly only about 50 or 60% of the time. You could stand at the bedside and flip a coin and be right 50 or 60% of the time. When a patient fails a spontaneous breathing trial, you should figure out why he failed that spontaneous breathing trial before you start doing daily spontaneous breathing trials. It doesn't make much sense to just mindlessly do spontaneous breathing trials every day and the patient fails. There's always a physiologic reason why the patient failed. And so you may have to do a little detective work and get you a little checklist, and go through and see, well, what is the reason for this patient's failure? And then you fix that problem, and then you can extubate the patient. The discontinuation of mechanical ventilation is not achieved by weaning down the pressure, weaning down the respiratory rate. We have to fix the problem that caused the patient to need a mechanical ventilator before we can extubate him. So be a liberator, don't be a weaner.